Hello and welcome to GastroVision. I am Dr. Qazi Sohail from Government Medical College, Srinagar, and today's topic is management of acute caustic ingestion. Acute caustic ingestion is a true emergency in gastroenterology. A structured approach helps prevent life-threatening complications and ensures timely surgical or conservative management. In this video, we will go through the complete algorithm, including CT grading, Zargar's endoscopic classification, and nutritional management step by step. Focus first on airway, breathing, and circulation. If there is airway compromise due to laryngeal edema or burners, secure the airway immediately. Perform early intubation or even tracheostomy if needed. Next step is assessing local and systemic complications. Assess for complications like mediastinitis, pneumoperitoneum, or perforation. If you suspect any of these, proceed to contrast-enhanced CT of chest and abdomen. CT helps classify the depth of injury. Let's look at the CT grading. Grade 1 is normal appearing mucosa and GI wall. Grade 2 is hyperenhancement of mucosa with hypodense areas of wall edema. Grade 3 is loss of post-contrast enhancement, wall blurring, and perigastric fat straining, all indicating transmural necrosis. If CT shows perforation or grade 3B transmural injury, proceed to surgery immediately. If no perforation, manage based on CT grade. Next step is CT grade-based management. CT grade 1 or 2 needs conservative treatment, that's nil per oral, IV fluids, PPI, and observation. Allow liquids once the patient can swallow. CT grade 3 needs ICU admission, close monitoring, nutritional support via nasojejunal or TPN. If clinical worsening or perforation, then surgery is indicated. Now the next step is upper GI endoscopy. If the patient is stable and CT rules out perforation, perform endoscopy within 12 to 24 hours. Endoscopy helps assess mucosal damage and guides further management using Zargar's grading system. Zargar's classification grades mucosal injury based on severity. Grade 0 has normal findings, Grade 1 has edema and hyperemia of mucosa, Grade 2A has superficial localized ulcers, friability, hemorrhage, and blisters. In Grade 2B, there are deep ulcers with friability and hemorrhage. In Grade 3A, there are small scattered areas of necrosis. In Grade 3B, there is extensive necrosis. This grading is critical because it predicts both acute outcomes and late stricture formation. Next is management based on Zargar grade. In grade 1 and 2A, there is mild mucosal injury. Start clear liquids once patient can swallow. Discharge after observation. In grade 2B and 3A, there is moderate to severe injury. You need to admit the patient, keep NPO, start parenteral fluids, PPI, and nutritional support, and monitor for perforation or infection. In grade 3B, there is full thickness necrosis. It usually needs surgical intervention, such as resection of necrotic segment. Next is nutritional assessment and support. Nutrition is the cornerstone of recovery. Here is how to decide the route of feeding based on the severity of injury. First, assess endoscopic grade of injury. Low grade, that's less than or equal to grade 2A, start oral feeding once able to swallow. High grade, that's greater than or equal to 2B, begin nasojejunal feeding if tolerated. If enteral feeding is not possible, shift to TPN, that's total parenteral nutrition. Look for contraindications to enteral feeding like perforation, active bleeding, or severe obstruction. If none of these are present, enteral nutrition is preferred as soon as possible to maintain mucosal integrity and prevent bacterial translocation. Next step that's important is monitoring and clinical worsening. If the patient develops worsening pain, fever, tachycardia, or peritonitis, repeat CT scan to rule out perforation. If confirmed, then proceed to immediate surgery. Now let's summarize this all. Stabilize airway, breathing and circulation. Do CECT to rule out perforation. If perforation is present, do surgery. If patient is stable, do endoscopy within 12 to 24 hours. Grade with Zargar Classification. Manage conservatively or surgically as per grade. Ensure early nutritional support, that's nasojejunal or TPN. Monitor for clinical deterioration. So that's the complete algorithm for managing acute gastric ingestion, from initial stabilization, imaging, endoscopic grading to nutritional care. If you found this video helpful, share it with your friends. Thank you for watching this video and see you in the next video.